Lori Bostic-Hammond, and I'm a pediatrician at Santa Clara Valley Healthcare who has been in practice for over 20 years. Today, I want to talk to you about something that affects patient care every day, yet often goes unnoticed: the language we use in medical documentation and how it shapes patient care and health outcomes. Let me start with a scenario. Consider an 8-year-old patient, actually the same child, documented 2 different ways. Chart 1 reads, disruptive child with poor behavior control, aggressive and defiant during exam, refuses to follow simple instructions, mother clearly overwhelmed and ineffective with discipline. Chart 2 reads, child demonstrates increased motor activity and difficulty focusing during examination, shows anxiety during medical procedures. The family reports challenges with current behavior management strategies and is seeking additional support. Same child, same behaviors, dramatically different documentation. And here's the critical part. This difference in language directly impacts the quality of care that child and family receives. Today, we'll explore 3 key objectives: recognizing how language impacts patient outcomes, developing practical documentation skills, and creating institutional change. The words we choose aren't neutral. They shape how we and other providers perceive and treat our patients. Let's look at a few common examples of stigmatizing language compared to more neutral language. Instead of non-compliant, which suggests willful disobedience, we could write has difficulty following treatment plan, and then explore the barriers that the patient has been experiencing. Rather than defensive, we can document patient expresses concerns about previous care experiences, or patient demonstrates protectiveness when discussing sensitive topics. Instead of morbidly obese, which carries judgment, we can use person living in a larger body or person with higher weight. Instead of drug seeker, we could document person with substance use disorder. Now you may be thinking, aren't these just semantics? But here's what happens when we use stigmatizing language. When we label a patient as non-compliant, we reveal an assumption that the problem lies solely with the patient, overlooking barriers like medication costs, health literacy, or transportation issues. This creates confirmation bias, which means that future providers look only for evidence confirming that narrative. And here's the critical data. Research shows that 82% of text in inpatient progress notes is copied from prior documentation. When you document an initial encounter with stigmatizing language, that language gets perpetuated through 82% of subsequent notes. Your words echo through the entire medical record, shaping every future interaction. The language we choose doesn't just describe our biases, it actively perpetuates them and shapes how others will perceive and treat our patients. Stigmatizing language doesn't affect all patients equally. Certain populations face particularly high risk. People with mental health conditions, substance use disorders, and chronic pain are frequently labeled as drug-seeking or difficult. Patients with disabilities have concerns dismissed or attributed solely to their disability. People living in larger bodies encounter weight-based stigma with symptoms attributed to weight rather than investigated. LGBTQIA2+ communities face bias in documentation. Patients who are affected by the social drivers of health, such as poverty, housing instability, and food insecurity, have circumstances documented judgmentally rather than contextually. And communities with histories of medical discrimination, particularly based on race and ethnicity, experience this most acutely. Black, Indigenous, and other patients of color are more likely to have pain undertreated, symptoms dismissed, and stigmatizing language used. This reflects and perpetuates generations of medical racism. In pediatrics, children with behavioral challenges get stigmatizing labels that follow them for years. Adolescents are particularly vulnerable to judgment around mental health, substance use, or sexual health. And we describe parents and caregivers with blame-based language. Mother is overwhelmed and ineffective, rather than acknowledging complex challenges and offering support. The consequences of stigmatizing language in the medical record are significant. When we use objective documentation, that same child I mentioned earlier gets a comprehensive assessment, screening for underlying conditions, family support, and connections to resources. The family feels heard. But with stigmatizing documentation, providers are more likely to conduct brief exams, focus on behavioral correction, and provide minimal investigation, so families leave feeling blamed. Stigmatizing language creates a dangerous cycle. Once initial stigmatizing documentation exists, it creates diagnostic filtering. Subsequent providers read notes with a pre-existing bias, interpreting new symptoms through that stigmatized lens rather than conducting objective assessment. This creates altered treatment approaches, less thorough workups, fewer specialist referrals, and dismissal of legitimate concerns instead of proper diagnostic testing. The result? Misdiagnoses. Patients with stigmatizing language experience significantly longer times to receiving accurate diagnoses. Conditions like autoimmune disorders, neurological issues, or pain syndromes progress undetected. This leads to more advanced disease at diagnosis, more invasive treatments, and can lead to permanent preventable damage. And the psychological trauma patients experience from this cycle is profound. Patients internalize that they're not believed, that their suffering doesn't matter. This systematic dismissal causes lasting harm, affecting future care seeking. For high-risk populations, the impact compounds. A Black patient with chronic pain faces both pain stigma and racial bias. An adolescent with anxiety faces both mental health stigma and age-based dismissal. Documentation matters and has a lasting impact on the lives of our patients. So what can we do? Practical strategies can be implemented at the individual and institutional level. Individual actions include using person-first language in order to emphasize the person and view the disorder, disease, condition, or disability as only one part of the whole person. Describe what the person has rather than what the person is. Person-first language avoids using labels or adjectives to define someone. For example, saying a person with diabetes, not a diabetic, or a person with cancer, not cancer patient. And use objective language that is focused on observation, not interpretations. If you find yourself writing refuses, non-compliant, or drug-seeking, pause and reframe your wording to objectively reflect the patient's experience. Conduct personal documentation audits and review recent charts for patterns in your language. Institutional strategies include the implementation of electronic health records, modifications with neutral templates, and real-time language flagging. Instead of free text for non-compliant, use structural fields. When documenting medication adherence, include documentation of the percentage of the medication taken and what barriers have been identified with drop-down menus. Require mandatory training, including onboarding workshops, annual refreshers, and specialty-specific training for high-risk areas. Develop documentation guidelines with regular audits and peer review. Here are some examples of what your charts might look like before and after interventions. Before, non-compliant patient refuses medications. After, patient reports difficulty with medication schedule. Barriers include cost and complex dosing. Before, drug seeking appears manipulative. After, patient experiencing pain rated 8 out of 10, requesting comprehensive evaluation. Before, difficult, anxious, attention seeking. After, patient demonstrates anxiety during exam, reports feeling overwhelmed, mental health screening indicated. These focus on observations and patient-reported experiences rather than judgments. Every time you document, you're not just recording information, you're shaping the care that patient will receive from every future provider who reads that chart. Today, I challenge you to make a change you can do on your own. Review your own documentation. Look for one instance where you can replace stigmatizing language with objective, person-first language. Just one. And notice how that small change can shift your entire approach to patient care. To make a change with minimal collaboration, partner with 1 to 2 colleagues and review each other's charts to identify instances of stigmatizing language you may have overlooked. And on the institutional level, consider implementing documentation guidelines, electronic health record modifications, and training programs. Our words matter. Our patients deserve dignity in every interaction, including the notes we write about them when they're not in the room. Thank you for watching, and thank you for committing to better, more compassionate care through better documentation.